Probably about 3 o'clock in the morning, foot pain, right? So, what are we thinking with this patient? Recliner, left foot supported by a pillow.
Sepsis.
Huh?
Sepsis.
Why are you thinking sepsis?
Because I read it.
Can you tell me one thing in here that tells you sepsis? Just one.
Low blood pressure.
Low blood pressure. What's her blood pressure? This is a 20-year-old female. Is that low?
I'd say it's kind of low.
What's your blood pressure?
Yeah, I was about to say
120?
she's an
That's not low for a female.
That is not something that we're concerned about. So you know, like when you go into a house and they say, oh, hey, I got high blood pressure. And you're like, oh, let me check your blood pressure. And it's like, oh, I got a blood pressure of 150 over 70. And they're like, oh, that's high. It's like, really? What's your normal blood pressure? Oh, it's 140. It's like, oh, okay. So like the highs and lows that we really become concerned about, 100 is not on the low end that we're, like that's not even something that I'm just like, hey, cool, you're super healthy. Awesome. So I'm not concerned about the blood pressure.
the fever that's not going down.
Well, she has a cut on her foot.
Heart rate's above 90, respiratory rate's above 20 with a known infection.
Oh, Hans, so for some reason you just like blurt it all out, right?
All came out at once.
It all came out at once. Everybody caught that, right?
Yeah.
Nope.
All those are bad,
They're not great.
right? How many of those are outside what the norm is for somebody? Respiratory rate is 24 normal breathing rate? No, not usually, unless this person just got done running or exercising or doing something like that.
She did because her foot.
Right, no, she's kicked back with her foot up, relaxing on the couch. Not normal, right? Respiratory rate. Okay, how about heart rate?
Above
110?
No, not really.
So,
Terrible shape.
hey, I'm right here. I'm right here, okay?
She's-
So I have a resting heart rate of 110. Okay? That was when I was on the caffeine. Now, now we're at 60, okay? All right. So a heart rate, so a lot of this is, you want to know what's normal for this person, okay? So there may be people out there that have a resting heart rate of 110, but typically, do we see that?
No.
No. So anything that becomes abnormal, you need to figure out what their norm is. You can't take just the general population norm and say, hey, you're outside the norm, right? Just like normal sinus rhythm. Do we have a normal sinus rhythm?
No.
No, it's more of a sinus rhythm, okay? That's one of my pet peeves. People will put NSR on their charts and stuff. I'm just like, hey, like there's nothing normal, right? It's like, is that normal for them or is it not normal for them? Right? So normal is like within normal limits on your vital signs. Is that a good thing to say over the radio? Or are you gonna hear it from me afterwards?
Okay,
Right?
hear it.
It drives me bonkers, okay? So you don't know what's normal, okay? Okay, so we have a fever that won't go down, yes?
Say it's within 2 patients still alive.
You could, or you just tell them, spend 2 extra seconds and actually give them what the numbers are. Yeah. All right, so pale, hot, dry skin, heart rate of 110, oral thermometer is not available. Why is the oral thermometer not available?
Because you don't need it for
Because you
sepsis alert.
guys forgot to check the batteries.
But it's still
You didn't do your daily check, just like your kids, okay?
Is a rectal thermometer?
You can have a rectal thermometer if you want.
And what does the site of the cut look like?
Ooh, I don't know. Ooh, so now we move on. 1-inch laceration with no active bleeding, red, swollen, and painful. Oh. Okay. What do you think? Don't read this yet.
Oh.
Try not to read it. Gosh, you guys read so fast. Okay, so just read the first one. So from now on, read in sections. Stop in sections. Okay, I'm a slow reader. Okay. So what do you think? Top appropriate?
No.
Appropriate recommendation?
No.
No.
They already qualified for a sepsis alert.
Do they really?
Known infection above 100,
You don't have it in battle box.
but you don't need it.
It's one of the things on the list.
2 of the 3.
No, there's 3 things, and then there's the
Plus.
list that has 3 things.
Boom. Plus. Yes, there you go. Oh, kids on it. Mose. Or not Mose. Bonds just got slammed. None of you guys know Mose. We were just, I was just talking with
I
you.
know, we all know
We
Mose.
were talking about Mose.
Yeah.
Yeah.
God, I just took it.
Yeah. Okay. So Michaela comes out of right field and saves the day there. Good job.
I'm still taking that
Can
patient.
you repeat what you said for us who could not hear?
For a sepsis alert, there's a list with like 3 things on it, and then there's another list in the second one that you have 3 things, and mine was
Plus.
only focusing on the one with the 3 things and not the other. So you need to have a fever or a like diminished LOC, and that's one thing. And then there's the list where you have to have heart rate over 90 in Lane County. I don't know other ones. And then
100.3. So
yeah, fever over 100.3 or under 96 something.
it's 96.
96.8.
Yep.
96.8. And then what's the other one on that one?
So respiratory rate.
Oh, respiratory rate over
Respiratory-
20.
Yep.
And then the very last thing is you're entitled.
Entitled under 25.
Yeah.
Okay, so we don't have our entitled that qualifies us. Okay.
Darn it.
Oh, man, so close.
Thanks for saving me.
Okay, so boom, we're back up here. Appropriate.
No.
Is there anyone in here that likes the option there?
No.
Not a single person?
I kinda like it.
Ah, thank you. This will happen all day in the field. Okay? This happens all the time. Why do you think that happens? Why do you think people get recommended to go to urgent care?
Because riding on the
Is
ambulance.
she acutely ill
No.
in the general presentation?
It's not unlike
Right, so right then and there, she's not dying right in front of him, right? And most of the time, these don't progress into something, anything worse, right? So somebody cuts their foot, yeah, okay, so then maybe their heart rate's elevated because they're in pain, right? So this, me personally, I can even see myself doing this exact thing, right? Being like, hey, there's no reason for you to go to the ER. I want you to see your PCP, get some antibiotics. Yes, it got a little bit of an infection going. But everything else, there's nothing that's really jumping out that's saying, sepsis, 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 right? Because we would have done our entitle and we would have checked it and it probably would have been fine. Because she hasn't gotten into that point where she's septic yet. Is she at the beginning phases of it though? Are we rolling the dice, crossing our fingers that she gets the antibiotics beforehand?
every infection that you go on.
Right, and so that's where you have to pay attention to, we have multiple things, multiple factors that are telling us, hey, here's a little red flag, here's another one, right? So there's not just a couple of them, it's not just one that's popping up saying, oh yeah, you got an infection because it's swollen and it looks like that. Now we're adding in our respiratory rate, we're adding in our heart rate. So now we're giving extra things. You know how we talked about if you're gonna needle decompress somebody, just because you have one sign doesn't mean that's what you gotta go. So you build the case to call it that, okay? So there's a little bit of a case starting to be built, but have we built it yet? Not really. So I would be okay sending this person to urgent care. So now we can advance down to paragraph number 2, where things go sideways. So she went to urgent care, awesome. Things changed?
Mm-hmm.
Didn't go better.
Oh, boy, things are really going sideways quick. Huh. Hopefully you're not working at 48, right? And you're not working day 1 and day 2 and be like, hey! I remember you from yesterday. Oh, let's see if I can, oh, yep, you're still in the computer. Yep, still here. Okay, let's fill this out, right? Hopefully you did a no patient chart on it, right?
Well, isn't that kind of her bad? She did tell her to go to urgent care and she waited till the next day.
Well, that's what we told her to do, right? We told her to wait till the next day. Who's the educated, informed person here?
You suggest send it in the morning and refusal to
Okay? But who is the informed person here? Who is the educated person here?
Paramedic.
Who is giving this person that has no idea what's going on with their body advice?
The paramedic.
So when you go to the doctor, what are they doing? They're making educated guesses, right? So that's all we were doing. We were making an educated guess. Did we miss?
Yep.
We did. Okay? Now you got a super sick person, right? So, it gets worse. Like it could get worse.
It's very sad.
Is this a real case?
Yes. So this isn't my same patient that we did 3 different hypovolemic shocks on. This is a real person.
So, if the paramedics had taken her originally to the ER, would her outcome have been different?
So what do you think? think they would have recognized the potential? Do you think they would have recognized the infection? Do you think they would have run some more tests that would have shown increase in white blood cells and showing antibiotic treatment sooner? Do you think they'd find that stuff out in the ER? Absolutely.
Blood culture on
And
it.
if the
Yeah.
information they were given initially,
They would've run a blood culture on her.
and she went the next day, then
They would've given her.
So you get the antibiotics quicker into the system, which helps fight the infection, which then helps preserve things. Okay, it helps advance, decrease the chance of moving
so
into.
it was a matter of hours difference.
Yes,
When they're
it
not
can make a huge difference.
For something seemingly
Yes.
minor.
Yep,
That's insane to me.
it is super insane, right? So as paramedics, what could we have done differently, other than, yes, take her to the hospital?
So on the initial, when you arrived at the scene the first time, I missed the, was her foot, how far up did it look like her foot was red, was my question.
Are you saying blood streak?
That's my question.
No
is
blood
how
streaking.
far
Nope,
extended.
it was just swollen, big, swollen foot.
That would be
around
my
it.
first red flag right then there, as opposed to just the site itself. Really big.
So what other kinds of things would you wanna, so this doesn't give you all the questions that they asked, right? So what kind of questions would you want to ask that would give you a better picture?
Was it pussy?
Was it pussy?
Like,
No.
what was the timeline?
Yeah.
Was it
That's
getting
for
incredibly
prevention.
worse recently, or has it been slowly getting
Did
worse?
it say the weekend? Spent the weekend
Yeah.
at the beach and cut her foot.
So what
So
day is
within-
this?
We're gonna say within
Over
7
the past
days.
several days, her
Several
foot
days.
has become, so like within a week and a half
Within
or
a week,
something like that.
yep.
So I know for, at least for back home, whenever you cut your foot on a piece of glass at my local beach, and it,
San Francisco, right?
oh
Oh,
yeah,
yeah, okay.
bay water is not good, but you cut in the water, it's a, like, you should go to the hospital, because you don't know what is in the water and what could have gotten into your system if you've drawn blood. That's just a general rule. So for me, her cutting her foot on a piece of glass while walking in the ocean, personally is a red flag, because there could be infection from that.
Yeah, so you have all kinds of infection happening that you're gonna have to work through, yeah.
Did she already see her primary care?
No.
Had she finished her course of antibiotics?
No. Did it say that she went to it?
No.
No, had she taken it? I'm asking
No.
the question.
No, this was, you were the first call to help.
And she just had Tylenol.
Yep, took some acetaminophen to try and help for the fever. Yeah,
Like, has she been nauseous, throwing up? Is there like red lines coming up from where the infection
No.
site is?
nothing.
Discharge.
I really wish we'd gotten it tested.
No, really wish you got it, Tom.
Wish we weren't so bad at doing checks.
The swelling
Yeah.
progressed, right? as-
Progressed over the 7 days.
I
Right?
probably.
So what do you think, so with all this presentation, what, so my question would be like, so what's different? What made you call an ambulance now? Is
Yeah.
it the fact that you can't put weight on it? Because that's a huge red flag. If somebody has a cut on their foot, like, right, you don't wanna put weight, or you don't wanna do stuff, but like, what changed, like, over the last 3 or 4 days that made you be like, hey, I need an ambulance today? Right? That's one of the biggest questions that you guys can ask somebody when they call. It's like, okay, great, so this is a chronic thing that you've been dealing with. It's now 3 o'clock in the morning. So what changed recently that had you call us? Now, with that being said, do you have to be very diplomatic when you ask that question?
No.
So would you think that, so why'd you call us tonight is a good way of doing that? No, and I hear people ask that question all the time. What does that do to the patient?
Makes them feel bad.
I'm sick, what else?
Instantly goes on the defensive, right? So now you have this horrible relationship, everybody's angry at everybody else, next thing you know, they're like, can I have a different paramedic? It's like, no, you can't. And that's coming from the little old man that's yelling at you, right? So instead, it's like, hey, you make this approach of like, hey, so, you've been dealing with this for a while, so what changed tonight? Did it get worse? Did something alter? Did you hurt yourself differently? Did you do something different that made you need to call us? What's different? What's the big change, huh?
Was it her weakness and fever, or is it just not?
No, that's one of the questions that I would
Oh,
propose to her
gotcha.
that we don't have the answer. And that's what I'm saying, is what are the extra questions that we don't have, that we don't know the answers to, that would help us in making the determination, because there's enough red flags with this one where I would have asked these questions that would have led me down whether or not to send her to urgent care. Because there may have been something in there where I've been like, oh, yeah, we gotta get you down to the hospital because who knows? I mean, yeah, within the last 20 minutes it went from, hey, it was totally fine, to all of a sudden, boom, it's huge, it's into my joint, I can't move, you know, that kind of thing.
What would it have been better to ask, like, can a friend drive you to the ER? Like, equivalent to saying, recommending urgent care?
So if you need a friend to drive to the ER, so you're saying then the person needs to go to the ER,
No, but they don't need to necessarily go by ambulance.
right? No, so that's what I'm saying, is like, so I have a sandwich technique when I present something to someone, okay? So I have 3 options, okay? Well, actually, so I have urgent care, I have the ER, and I have PCP, okay? Whichever one I don't want them to do, which is go to the hospital by ambulance most of the time, I put it right in the middle, okay? And then I'll be like, hey, you know, we could have a friend take you down to urgent care or something like that, or we can take by ambulance, or you can give your doctor a call and try that. So why do you think I sandwich it?
Because people remember the start and the end of things.
They remember the first thing and the last thing that they hear, okay? So it's funny, because people didn't believe me, I'm like, watch. I go, very next call, I go, watch, I'll give it to them, I'll be like, I read the details, I'll be like, okay, you guys ready to see it? They're like, yeah. So I walked in there and I did the same thing, I pulled out the sandwich thing, I'm like, okay. Before we even got there, I'm like, all right, which one do we want them to recommend? I'm like, which one are we really pushing for? And they're like, hey, let's see if we can get the urgent care. I'm like, okay, cool. I was like, because if it's not urgent care, we're gonna get a call back. So I walked in, did the whole sandwich thing, but I started off with urgent care. And the funny thing is I threw in the 4th and I said urgent care again the 4th time. So it was the first and the last thing that they heard, okay? But the other things in the middle, you just kind of breeze through them, okay? So you can always recommend going all different kinds of directions. It's what you're gonna get, what you want your patient to get, okay? So these people, paramedics, whoever they took care of, took care of her, obviously felt it was a non-emergent thing, that she just needed antibiotics or something, or a PCP or an urgent care type of visit. They were significantly wrong.
If you went to your PCP, that could be like a month.
Right. Right.
Several weeks.
It's not, so that's one thing you guys will learn, like, as paramedics, like, we help people get into their PCPs, right? Like, I've called their PCP and says, hey, we're out here with Dorothy. Dorothy has a appointment next week. She can't wait, she needs to come see you. She's got an infection in her foot. They're like, oh, yeah, send her right in. Boom, they get ready.
Would that be the same as urgent care? If they're going to see a doctor that they know instead of
Right.
It'll cost less usually if they have like a standing.
Go ahead, yeah,
They're
I mean,
part of
so
that.
urgent care is there for quick fixes. PCP is there for long-term fixes. That's why we recommend people go to their PCPs versus go to the ER.
Because they have
A lot of the
their
times.
history.
They have their history, they know what they're on, they know what they're doing, okay?
But in
Alright.
terms of a timeline, it would be the same as going to urgent care, because it would be like the next day.
Yeah, yes, that's what you're going for. Yes, you need to see a doctor, you need to get in, these are the options that are available to you. You get to make the decision. Because I always throw it out there, so what do you want to do? That's the last thing I say. So what's your plan? What would you like from us? And that's why you sandwich it, so that they make the decision based on their thing. Like, I never say, hey, you need to go do this. It's like, what would you like? So it's their thought process, their decision that makes that, okay? All right, so, let's see. So this is so she went into septic shock, which is a portion or a part of distributive shock, all right? So the heart is okay, but you get massive vasodilation throughout the body, all right?
What causes the vasodilation?
Oh, are you guys familiar with Khan Academy?
Yeah.
Have you guys watched videos on there?
Yes.
For starters, I can't believe how awesome they can draw with a little cursor
mouse.
thing.
I think they hate that cursor thing. I'm pretty sure they got a system like this.
That's what I started, like, so we were watching this at work the other day, talking about this, and we're like, it's gotta be something where there's a pen associated with it, type of thing. So with the septic shock, so long story short, does the infection usually happen in the bloodstream? Yes or no?
Doesn't
The
start
infection
there.
happens outside, right? So how does the body react to fight infection outside the bloodstream? Mons.
So it's your.
You're excited, I like this.
Well, no, it's your
Finally.
immune system's response to vasodilate. I don't remember what hormone it is. That
Lots of
actually-
hormones, we're not gonna get into hormones, we're gonna get
But
vague.
it's actually your body's natural reaction to the infection.
Okay, so what does the body send to fight infection?
White blood cells.
So you got your white blood cells, right? So the white blood cells flood the area, and so then the white blood cells travel via blood, right? So the white blood cells have to get from the blood to the infection. Yeah?
Yeah.
So, I'm really bad at drawing this, and this, you could really actually look it up on that Khan Academy thing. They did a really good job of drawing it. So just very vaguely, so you got your vessel here with your white blood cells, and there's a bunch of them in here. All right, get your infection up here. And then, so these have to get from here to there, right? So what happens along the vessels? What does this become? Very what?
Porous.
Porous and permeable, right? So this has to, and there's a lot of hormones and stuff involved that I'm not anatomy proficient in.
Physiology.
Physiology, okay? Well, no, the hormone is part of the anatomy, and then the physiology becomes that, right? So, long story short, these red blood cells have to get in here. What do they take with them when they go? Fluid, right? So these channels open up, and fluid leaks up into there. Okay? So then we get this massive dilation, because then these vessels start to kind of become holy for the most part, and stretch out, and vasodilate out, and so everything becomes this giant container then. Okay? So as it becomes porous, fluid starts to transfer out, causing a massive drop in blood pressure. Sorry, Mark. You need to just have that thing on like one of those where it follows at all times. And so, so you get this massive drop in blood pressure, right? So how do we fix this as paramedics?
Dopamine.
Okay, so we can go dopamine. What's the big way? Fluid. The quickest and easiest,
Fluid.
right? So we dump in fluid, right? So we give 2 liters of fluid as quick as we can to people in septic shock. So when we say as fast as we can, what are we doing as we're giving it?
Two IVs wide open.
IVs wide open.
2 large, so are we treating this person like a trauma patient almost?
Yeah.
Yeah.
Right? So what are we doing as we give this fluid?
Monitoring lung sounds and blood
Monitoring lung
pressure.
sounds, right? So we don't want to overflow them. Are these people highly susceptible to overflowing them?
Yes.
Are they sick already?
Yes.
Do they have issues within their circulatory system already?
Yeah.
So we have to be very, very careful as we're giving them the fluid, okay? We can overload them very, very quickly, okay? So, other distributive shocks, we have anaphylaxis and neurogenic. So these all used to be separate types of shock. Like neurogenic used to have its own thing, and then they kind of recategorized our shocks. So now we have neurogenic. So what would you think neurogenic shock? What are you thinking when you hear neurogenic shock?
Something with the brain.
Trauma to the brain.
Usually it's
Spinal cord.
trauma-related spinal cord injuries.
Infection, like meningitis.
Okay? So you have somebody. These are the craziest patients. Let me look at them. Okay? So I gotta do colors. Okay. So you have somebody, they fall. They fall off a ladder. Okay? Don't laugh at my drawings, okay? They fall off, okay? And they end up fracturing. We're just gonna say that's their cervical, or their
I think they got cut in
vertebrae,
half.
okay? So they end up fracturing midline, lower T, upper lumbar region, okay? Full sever of the cord. What would you expect to happen within the body?
Vasodilation below the injury.
Okay? What do you guys think about that? Does Mons agree? I also agree. So you're gonna get from that injury point down, you're gonna lose all regulatory ability, okay? Because you've lost nerve function from the brain, completely severed here, okay? So there's nothing regulating anything from this point down, okay? So you get major vasodilation. So once again, what happens with major vasodilation?
Blood pressure drops.
Blood pressure drops. So how are they gonna present up here?
Fine.
Normal.
No. They're gonna have altered mental state, because they start getting drowsy and woozy and.
So what's it gonna look like up here compared to here? The line of demarcation.
There's 2 different patients.
There you
on
go.
top and
So you're gonna get this
You
line.
take like a blood pressure on the leg?
tail on
You're gonna
top.
get a line, no, you're not gonna take blood pressure on the leg. So you're gonna get a line of demarcation
your
here,
thought.
okay? So a lot of times what you'll see is you'll see a very distinct spot on the body. Sometimes they're diagonal depending on how the injury occurred. But you will see pale, cool, clammy lower extremities, and you'll see pink, warm, and dry upper extremities, okay? So when it comes to the neurogenic portion of it, the neurogenic shock, what would happen if you just were way down here and you had a sever down here? And you get vasodilation from here down.
About lower extremity problems as opposed to thoracic problems.
Okay, but what does that, so think about like when we're thinking about shock, and what do people normally think of? Hey, I'm going into shock, right? So what is the textbook categorization of shock? Okay, so they get dizzy, lightheaded. What happens with their blood pressure?
Drops.
Right, so blood pressure drops. So neurogenic shock, a lot of it is going to depend on what level of injury it happens. Because if you just vasodilate down in part of your legs, would you think that would, and everything else is fine, do you think that would potentially drop your blood pressure a whole bunch?
Not as much.
Not necessarily, right? But now say you get something up here about like the nipple line region. What about now? So now you have this entire container that has just opened up everything, right? So now you will potentially start off pink, warm, and dry up here, but what can eventually happen?
The lower extremities.
So the lower extremities have lost all of their ability to regulate. So now this is the only thing that's regulating, but now it's trying to make every attempt it can to make sense of what's going on, but the blood pressure is dropping. So now you start to get pale, cool, diaphoretic up above as well. Okay? So these are pretty crazy patients to actually legitimately see, because this line is pretty, when it's a full-fledged legit neurogenic reaction, like you can be like look at it and it almost looks like like a line. They had I don't even just call it line of demarcation, but it's like this. Looks like you were laying out and somebody put sunscreen across, and it's like boom, everywhere there and everywhere up. Okay, different colors. Yeah.
So would you assume that somebody in neurogenic shock has a spinal injury?
Yes. Almost every time. There can be infection, like somebody said meningitis earlier. Yeah, so you can end up with infections as well that can potentially cause this type of thing, but the majority of the time we're going to see it is going to be in those traumatic related events. All right. Yes.
How fast of an onset is it?
Virtually instantaneous, because it instantaneously loses all muscle. It loses all tone, muscle tone, everything. It becomes instantaneous.
So when we arrive on scene of like a traumatic injury, we'll just immediately feel it's like, oh, this is what it is. We see it.
Yeah. So the hard thing with the pre-hospital setting is are we really going to be able to like legitimately see, or does it take a little bit of time before we can find things?
Well, the blood pressure didn't
Do people, when you show up, are they naked?
Well, hopefully not.
Not usually.
Sometimes.
I mean, sometimes yes. When they throw open the door, they're naked. They're like, I got my backpack. I'm ready to go. And I'm like, oh, hey, let's go in and get you some clothes, right? So in traumatic events, it's going to be a little bit harder to recognize. And so what you'll start doing is you'll recognize, hey, you got paralysis, you got numbness, you got something going on. What does that do to you? And a suspicion goes up, and you start to investigate that a little more. Okay, and then you're just like, oh, you start lifting up things. You're like, hey, you start doing the sensory test all the way up. Where do you lose sensation? Where do you lose? The craziest thing is like when you really think people are like, because when you do these, when you're like, hey, can you feel this, can you feel this, can you feel that, as you're doing things, there's times, what do we do? Hey, can you feel this? Can you feel that? Uh-huh, yeah. Is that sharp or is that dull? And what are we doing? Nothing, right? We're standing there, but they don't think so, because a lot of people will go into denial and they're like, oh yeah, I feel that, because they don't want to realize, they don't want to think, hey, I'm paralyzed kind of thing, right? So you got to do some of those false tests, false positives on people, okay? All right, so any questions on neurogenic stuff? Cool? All right, anaphylactic. This is the anti-basic stuff, right? So anaphylactic shock, how does that work? Histamine?
Yep, in the
Release?
mast cells.
Huh?
From the mast cells.
Mast cells. So how is a anaphylactic shock person going to present?
Difficulty breathing and low blood pressure.
Possible hives.
How do we fix it?
Epinephrine, a pressor.
Pressors, right? So same kind of thing, distributive, the heart pump's working fine, but everything is vasodilated, right? So we need to shrink things back again. So this person is a neurogenic shock. Do we give them epi? Do we give them a pressor?
No, because it wouldn't work.
Right. See, so knowing, we talked earlier about, hey, you got to make sure you know what type of shock we're in, because each treatment has a different approach. How about our septic patient? Do we give them an epi? Hey, guess what? You're in shock. We're gonna give you epi. No, right? That's gonna be really bad. They're already trying to compensate. Now we're gonna overload their cardiac work. Okay. So anaphylactic presents. Give me one presentation, Dustin. One sign.
Swollen airway.
Swollen airway. James.
You get rashes and hives.
Across your midline.
Across your midline. Okay. Describe.
So if you get stung by a bee somewhere, but you get hives on the other side of your body, that's an indication that you're in an anaphylactic reaction. Versus just like you got stung by a bee type of stuff.
So if you go on a call and somebody says, hey, I got stung by a bee, and they're like, hey, yeah, I have my EpiPen, but I didn't use it, what should you think?
They have a possibility to go into anaphylaxis.
They have a high possibility, because why? Why do they have an EpiPen?
Because they've had the issue before.
They've had a reaction before, right? So same kind of thing, like if somebody has a reaction so everybody just automatically chalks anaphylaxis up to bee stings, right, most of the time? What other kinds of things can people have an anaphylactic shock?
Food allergies.
Shellfish, food.
Are you saying stings or what could cause
What could
anaphylaxis?
cause an anaphylactic reaction?
Food, medications.
Cobra venom, maybe.
Oak trees.
Anything, right?
Yeah.
So that's the thing, anything can cause these. You can have any sort of allergic reaction can turn into an anaphylactic reaction, right? So just because you've been stung 20 times by bees and never had a reaction, this next time you could have a reaction to it, okay? So we give epi. Do we give epi first time? So with an allergic reaction, where is our cutoff line? When do we call it anaphylactic versus an allergic reaction? So let's go with just allergic reaction. Versus anaphylaxis. All right, so allergic reaction.
Localized.
You kids still anaphylactic.
Why are you so?
Sorry, that was out loud. That was supposed to
Damn.
be internal.
It's funny because, see, you guys are catching on to some of my tricks, so now you know what that means. I gotta make scenarios harder on you guys now, so that I can say, so you guys can all thank Chandler for the next one.
He made it more exciting.
Yeah.
Yeah.
All right, so allergic reactions.
Localized.
Your breathing isn't life-threatening yet.
Boy, that's it.
No breathing.
What if I have rash?
I've had rash.
That's local. Or
Localized rashes.
I've had a rash from pre-workouts.
Is it like?
A rash. It's just a nice reaction. Just please don't call 911. So did you guys hear that?
I did not call
Oh,
911
hold on.
for it.
So So
I took
Monsieur
Benadryl.
just says
No.
he had an allergic reaction to pre-workout. Just so you know, it's called a niacin reaction,
Oh,
and
man.
your entire body turns red. I kid you not, 911 has been called for somebody having a niacin reaction.
Did not call
The
911.
best part is
It was
I
mine.
swear it was gone.
It was.
But
I just.
we showed up, and of course, all of us on the crew, what do we drink? We drink pre-workout stuff.
I'm ready too.
So we walk up there, and we're just like, and this guy's like freaking out, right? He's just like, look at me! He's like, I'm red! And he pulls it up, and he's like, I kid you not,
I think I still. have
he was like
pictures.
this red. Like, this dude was red. And we're like, yeah, man. He goes, this is the first time I ever tried this stuff. It's crazy insane. He's like, all my nerves are firing off. I was like, dude, let me guess. I go, let me guess, it feels like you're on meth right now. He's like, I don't know what meth feels like, but
That's a
if
loaded-
I was gonna say this was meth, this is what I would say it was like. I'm like, yeah, dude, you're having a niacin reaction. He's like, what's niacin? I was like, dude, and I picked up his thing. I was like, did you read on here what's going on? And he's like, I was like, this is what I laid it out, man. It's like, I know it's a crazy feeling and everything. He's just like, so that means I'm gonna live? I'm like, no, you're gonna die. He's like, oh! He's like, I'm just kidding, you're gonna be fine. I was like, just go drink a whole bunch of water and it'll dilute it out, you'll be good to go.
Well, it was
But-
half off at GNC, so I'm done.
So that's
And it wasn't even that much. I was
So
like,
that's one of
what's
the things.
going on?
You never take the last scoop out of the pre-workout stuff. That last scoop is super high concentration, so that's another
It's
time when what's happening.
Dude, I bet he PR'd though.
I still worked out. I was like, oh, this is great. Like, I just feel itchy now.
Yeah, it's super itchy, super. All right, so going back to allergic reaction. So no real breathing effects. You can have some hives.
Headache.
Headache?
Yeah, you get a headache.
You get a headache? Okay.
Good
You
job.
vomit.
Vomit.
The onset might not be as rapid.
Slow. All right. Got a good picture of allergic reaction, right? So what's the difference between just a regular reaction and phalanxis?
It's fast.
Fast.
Compromised breathing.
Or airway.
Hypotensive.
There we go. Now we're talking.
Hell yeah.
So what do we do for allergic reactions?
Diphenhydramine. Maybe albuterol.
Natural.
Can we give epi for allergic reaction?
No, because epi is
just
treating
treating
the
the
symptoms
Benadryl?
to our anaphylaxis, not doing anything for the allergy.
Benadryl. So at what point do you cross that line? And make the
Airway.
determination that
Airway.
you are going to go with epi.
Airway.
Airway, as soon as the airway's involved? So what
Or
happens
they're
there?
not perfusing.
Hypotension.
So this is, so, I don't remember who I was talking with, but we were talking about, this is where, so we do a lot of judgment call stuff in the pre-hospital setting, okay? So this is where, it's like, you gotta look at how long it took them to get to this point here. Was this super fast? Or, hey, what's going on here? Is this something that we can take a little bit of time, try some of this stuff? If not, then we're on the cusp here. We're jumping back and forth. We got a little bit of this, it's kind of a quick onset, it looks really systemic, but I don't have any airway, like I got rash from top to bottom, right? Rash from top to bottom, that means it's gone full body, right? So compared to like a couple blotches here or there, if it's full body, I'm like, okay, we gotta really kind of pay attention now because this is what we don't want to happen. So so I have one question that I always ask people when this kind of thing happens, okay? It's my go-to question, and it helps me determine really where we are with this allergic reaction. Anybody have any ideas what kind of a question?
What usually happens?
No? No?
Difficulty breathing?
No, that's a quick and easy one.
Easy can tell.
So that's easy to look at them and be like, yeah, okay, you're having a hard time.
This is a
Very
question.
close. How does your tongue feel? Does your tongue feel bigger than normal? Does it feel awkward? Does it feel like it's tingling? Does it feel like anything like that? Because if anything is wrong with their tongue, what does that tell me?
Might become
Something
obstructed.
on
There is
Or-
something that could potentially cause conflict up here, and I need to be ready, okay? So if I have any sort of tongue irritation, and I have any sort of, this person's tacky at all, if we're still in the compensatory place, I may take a quick second, try some Benadryl really quick, and if not, I got my epi drawn up, ready to go, all right? And I'm gonna continue to talk to them about how that tongue feels, right? Obviously, I'm gonna look in there, and I'm gonna evaluate, see just how much, because a lot of times people are like, oh yeah, it feels kind of funny. Then they open up their mouth and you're like, oh geez, please don't make me have to intubate you, right? Because it's taking up just so much of it. All right, so we got our epi.
How does epi do for the swollen tongue?
It would be
Basically just causes vasoconstriction and just brings everything back down. Kind of like the angioedema they were talking about, where it just constricts everything down and just forces all the fluid back out into the rest of the body. Alright. We get epi. Anything else?
Diphenhydramine,
Okay, so we got our Benadryl, we got our epi. How much epi do we give?
0.3 to 0.5 milligrams.
I think they changed it just to 0.3.
They simplify it.
0.3.
Okay. So we got our epi. What else after that?
Benadryl.
Yeah, we already said Benadryl.
Oh, sorry.
Anything else?
I don't know if we've given it
You
yet.
guys ready? You guys ready to make a decision?
Yes.
ready?
Yes.
Okay, I hope so. So now what? What are the medications we have? What?
That's what I was
RSM.
wondering, like, I don't know if this.
So at what point does this
Turn into that.
turn into this?
And we don't wanna take all that time to do
Oh,
that.
hopefully it doesn't close, 'cause then.
So etomidate sucks, Kris said,
Okay.
fentanyl.
So that is, so with that, so I'm not saying, yes, this is the route that we want to go, right? This is the absolute route we do not want to go. But, once again, now, boom, we got to this point, we gave our epi, we gave 3 doses of epi. We're up to almost a full milligram of epi, 1 to 1,000. This person is totally hypotensive. You can hear very little air movement whatsoever. Person's getting nothing, SATs are in the 60s now.
They're probably turning blue at this point.
Oh man, things are going sideways, right? Once again, boom, we're at that decision-making matrix. Oh geez, what do I do? So maybe to the point where you have to, okay? This is one of those times.
Have you ever had that happen?
It is gonna take time, right? So this is why you guys are awesome at doing your math, right? That's why I said the whole 5-minute thing.
No, but I'm saying the time for like the induction agent to take and the like, how, you know what I mean?
So,
So if they're
so
seriously like no longer breathing, I know, yeah, we don't do the ICD one.
okay.
We're gonna go
That should
ketamine?
take you less than a minute to get that stuff. pulled
Okay,
up.
and it will affect, it will have an effect though? I mean, it will,
It will get an airway in there and you will be able to ventilate.
no, I don't mean
Hoping.
that, I mean the induction agent and the paralytic and the Versed, like those will take quickly? So that
Yes.
you- Yeah?
Yep.
Okay.
Yeah,
Are we gonna go with ketamine instead of
That's
etomidate?
what I was gonna.
in hypotensive, I would. Yep,
Hypotensive
because
and-
you're trying to do some vasoconstriction, you're trying to gain
Right.
extra ability. with it.
But if you show up and their airway is that compromised, are you gonna take the time to do a BP before you make your decision? Or are you making your decision based on they're in anaphylaxis? I'm assuming that they're hypotensive.
If you show up and they're to the point where they're at this, you're gonna lock them up, you're gonna drop the epi, you're gonna hit them with the epi, and you're gonna start getting your intubation stuff ready. And you're gonna pray that something changes between here and there, that's gonna affect, please, 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 please.
Is this a med control thing? Because for medical patients, we have a med control.
Absolutely.
If they've gone downhill far enough to go,
So, if you get to the point where it becomes a crash airway, boom, and boom, it's no longer, yep, you just go, okay? So, if you get into this situation, boom, we're back to judgment calls. If you don't have the time to call, you do it, you ask for forgiveness later, you explain why you couldn't, and then you just have to hope that nothing comes of it. Like, hope that you made the right choice, and that they're not gonna be upset with you.
Have you ever had like epi just not work?
Yeah. Doesn't always work. It's not the magic drug. They're even talking about getting rid of epi for codes now. I mean, they're talking about getting rid of epi for everything. So, so drugs don't always work. So think about like so it's a IM shot, right? How long does that take? A while, okay. Alright, and plastic sepsis.
Have you ever had to intubate someone whose airway is crushing, but they're still conscious, and you didn't take the time to do the induction?
Yeah, because we didn't used to have induction stuff.
Okay.
Yeah, so you can forget, I'm an old dinosaur, right? Like I intubated people like that were breathing, and you can almost stop them. Yeah, like I went in there and was like, okay, take a deep breath, and I tried. Yeah, so yes.
Okay.
So, could you explain why an epi or dopamine wouldn't work on a neurogenic shock, the vasodilate or vasoconstrict?
So epi.
Because isn't a systemic hormone and not gonna.
So epi. So I would say dopamine has the potential because you're just basically.
Because it's not going to follow the nerve
it's not following the
pathway.
neurogenic- yeah, it's not
It's
following
following
the
a hormone within the blood system.
Right. I would agree. I would think that the dopamine would have the potential. As for epi, I would have to look. I would have to do a little research on the epi, but I would guess that the dopamine, because
But
of the
but
depending on your
that
dose
but we
range.
wouldn't use a pressor.
No.
Okay.
Okay. So the last one. So you guys got like 5 minutes, right? Oh, sweet. Oh yes. Perfect. You guys will make it all the way through your shock, and then you'll be done. All right. So you got your obstruction.